Oh, man. This is the call you don't want like at 11 p.m. because there's no distal perfusion cannula in, and everyone is thinking, do you go to the lab and just get this out of the way, or do you wait for the call in the middle of the night to know that this leg is ischemic?
Hello, NIRS CathMasters. Welcome to the crisis control part of our VA-ECMO series. This is Nazli Okumuş, and we are back with Drs. Daniel Embender, Engage, and Marwan Juma. Check out the previous episodes to get caught up on the data and technical aspects of cannulation. As a reminder, Dr. Engage is trained in interventional cardiology and critical care cardiology, while Dr. Marwan Juma is trained in interventional cardiology and advanced heart failure. Dan, what crisis awaits us this time?
The crisis is here, team. It's 2 a.m. and I just got a call about a patient who just transferred to our CICU. She is a 50-year-old woman with ischemic cardiomyopathy who has presented in VT Storm and has crashed onto VA-ECMO with Impella CP at the outside facility. She has a 25 French venous cannula and a 17 French arterial cannula in the right groin, and the Impella CP is in her left groin. The intensivist is concerned about possible right leg ischemia on the side of her ECMO cannulas. And we need to decide whether to activate the lab for distal perfusion catheter. And I know that we had talked about in previous episodes, you would always put in a distal perfusion catheter in the non-ECPR setting, but here we are. So how do we assess for an ischemic leg, and what are our next steps?
Oh, man. This is the call you don't want like at 11 p.m. because there's no distal perfusion cannula in, and everyone is thinking, do you go to the lab and just get this out of the way, or do you wait for the call in the middle of the night to know that this leg is ischemic? It always ends up that you make the wrong choice and that you're really tired the next day. But just for what it's worth, our program has decided that we have gotten this call for ischemic legs too much. And so if possible, we'll just land these patients in our cath lab straight away when we first meet them. And we have a goal of making sure that limb complications are a never event. And so we have really kind of operationalized and developed protocols to just go ahead and put a DPC straight away. But let's say this patient gets lost. They end up in the ICU instead of the cath lab. Ultimately, leg ischemia results from an absolute or even just a relative decrease of arterial blood flow to the distal leg. And it can be caused by physical occlusion from the arterial cannula. It could be caused from selective perfusion of the profunda instead of the SFA. You could have femoral or iliac vessel damage during cannulation. You could have inadequate peripheral perfusion just to match your tissue demand. This may be due to a high level of vasopressors causing additional peripheral vasoconstriction. Or at the end of the day, this patient may have peripheral arterial disease and you've just stuck a large bore cannula in a diseased artery. So the first step when you get this phone call is clinical examination. Is the leg cold? Is it mottled? And what are the pulses like? Knowing what the pulses to the leg are like immediately after cannulation is very helpful to have a comparison. But obviously, if you've never met the patient, that is a piece of data you don't have. An arterial duplex is frequently performed to assess for flow into the distal arteries of the leg, and ultimately lower extremity angiography may be pursued. We also routinely use near-infrared spectroscopy, also known as NIRS, as a surrogate for distal perfusion. So if this is a patient that has arrived and we have already kind of set up in the CICU, we've kind of, gotten them all set for our facility, they would have NIRS placed on both of their legs. And this NIRS system monitors the difference between oxygenated and deoxygenated blood, which is known as a regional oxygen saturation. Importantly, this measurement doesn't rely on pulsatile blood. And this regional oxygen saturation essentially reflects uptake in the tissue bed that you're looking at. So our nurses monitor this value continuously, and I assume that institutions will have various protocols. However, when it was first published in the context of using NIRS for VA-ECMO, clinically significant events that warranted intervention were defined as those with regional oxygen saturations that dropped below 40 or more than a 25% from the baseline. So I think your first step is always just going to be this physical exam, and that really includes, are you cold? Do you have pulses? If you can get a duplex, this is helpful. And then if you knew this patient, for us, if they had been in our unit for a little while, we would be watching these NIRS and we would see that the NIRS would decrease. And all of those things are ultimately going to end up with this patient in the cath lab for a distal perfusion cannula. I should note that our standard protocol, just in an attempt to have never events with leg ischemia, is that we also put a distal perfusion cannula on the side of the impella every time also. So if you take this patient down, I wouldn't recommend waiting to get called again for ischemia in the other leg, and I would just reperfuse both of these legs.
And do you place the distal perfusion in the cath lab or in the ICU?
These are conversations we have had over and over for multiple years. Our group has a very healthy respect for the DPCs. And I think that we really, truly try to make sure that these are good sticks. We watch our wire under angiography and we do an angio. So the answer to that is that we try to get these patients to the cath lab in almost all circumstances. And the initial pushback for that was that these are high-risk patients. We're traveling. Why are we going to take all of these machines? But we had a couple situations where things went into the profunda or we dissected something. We felt like we were doing fine, and we actually inadvertently had dissections when we did them at the bedside. And so our protocol really has been that as soon as we get these outside hospital transfers, that we land in the cath lab, we meet them. Frequently, they need other things done also. It's, do they need their pulmonary arteries shot? Do we need to relook at the PCI because they're still having a ventricular arrhythmia? Do we need to do a right heart cath because they came with one in the groin? So normally we can find other ways to also optimize the equipment that we need. And we bring these patients to the lab and then do the DPC there. Earlier on, we were doing these more at the bedside, but our interventional group has pretty strong buy-in for taking these patients to the cath lab. What about you guys?
Well, the key is prevention of leg ischemia. So everyone gets distal perfusion. And what's unique about our system is no one cannulates for ECMO except the shock team within our group. So even within the 16 other hospitals within the Greater Houston area that's part of our system, we go in and cannulate. So I will place a distal perfusion if I'm cannulating in another hospital or my colleague is. So we rarely get patients without a distal perfusion cannula placed. And if an interventionalist is unable to place it, and typically we do it at the bedside, then there may be an issue with the body habitus or something like that, that we may need the surgeons to help us with that, but that rarely happens. So most of the time it happens at the bedside. On those rare occasions that we can't do it for whatever reason, they either go to the cath lab or the operating.
Oh, and that's interesting. I think that gets at how different regional care systems are structured. We have an active eCPR program and go and remotely cannulate for eCPR. But there are many, many facilities that send to our hospital where the interventionalists are learning and getting more comfortable cannulating for ECMO. And so it's not our team doing that. But there is a lot of trepidation, I think, even if they're willing to do the ECMO cannulation in our region, they're not comfortable with that reperfusion sheath. And we've also had some of them come in some really weird arteries, or maybe not even arteries, some unusual locations. So I think that we have more heterogeneity, it sounds like, than you guys do from who's cannulating. And so we frequently are on the receiving end of patients that certainly do not have antegrade reperfusion sheaths in.
A phone call about an ischemic leg is truly a nightmare for an interventional cardiologist. And thank you so much for sharing these pearls. It is so important to hear from different institutions, different operators, and how to act with different resources. So the decision is made. We are headed in to place a distal perfusion catheter for an ischemic leg. Marwan, what equipment do we need? And how do we decide on sheath size?
For the sheath placement, I would need an ultrasound to visualize the SFA. A lot of times the flows are going to be very limited, so a lot of it is dependent on color of the blood. Sometimes if you're occlusive, the color may not be even indicative that you're in the artery. So I guess that would be the benefit of being in the cath lab if you're doing it in the cath lab to look at the wire and wire position. But I use a micropuncture axis kit. And then in terms of the sheath, I use an arrow sheath. It's a little bit more flexible, and the standard is to use a 7 French. If I can do a 7 French, if not, we'll do a 6 French sheath. And for those cases, I try to avoid an ampulla super stiff and going below the knee, especially that I'm doing it at the bedside. So I just use a regular J-tip wire and I place the sheath. The key for this when I'm doing an antegrade at the bedside is to make sure that we have a dilating of the tract to be able to get the sheath in place. So sometimes I use a dilator of the sheath first, make sure that it goes in, doesn't kink the wire, and then I take it out and put the sheath in again and take the wire out after that.
Earlier in a previous episode, you walked us through your approach for the distal perfusion catheter before you place the ECMO cannula. But now, do you have any tips that you use in terms of your step-by-step approach, placing the DPC for a patient who already has ECMO?
Yeah, after I sigh and, psych myself up to do this because I don't actually love this stick. Sometimes it's really hard to maneuver around the cannula that's there. There's a lot of shadowing on ultrasound. You don't have flow. The blood vessel is super tiny. Maybe they have underlying PAD. But I think that what I found is that I used to try to leave the cannula exactly where it was and maneuver around. And that often led to me not getting the view that I wanted. So I cut the sutures that are there. I move this cannula out of my way. It turns out that you really can move it quite medial and lateral, so long as you're just cognizant that you're not pulling it back or pushing it in more. So just watch where it's going into the skin. So I optimize my view by moving that cannula a little to the side if necessary. And I often use a second set of hands to, if I need it moved, let's say medial, that they hold that cannula while I'm getting access. And then ultimately, I think that you just try and find the best ultrasound window that you can, and you stick. I am right-handed, but hold the probe with my right hand, stick with my left hand. So I do that like the micropuncture system. And then once I have the micropuncture sheath in, I always perform angiography to make sure that my runoff is into the SFA where I think I am. And then just like Marwan has mentioned, for some reason, getting the distal perfusion catheter, there's a higher likelihood than other angles, I think, and maybe it's that the skin is a little bit thicker in this area for some people. There's a good amount of tissue, but kinking the wire. So I usually nick more than I do for other sticks. And I go in over super stiff wire just to try and make sure that I don't kink the wire with this kind of very important stick. And then obviously put your cannulas back in place and suture everything once you have gotten your access. We use a 6-French destination sheath, so 45 centimeter destination sheath for our distal perfusion cannulas. I previously was at an institution where we used the arrow sheaths. They were braided and reinforced. We have found good success with the 6-French destination, mainly because what we do with this is that we had found that the sidearm of the sheath is sometimes where we get stasis and clotting. And so the destination sheath allows us to fully remove the hub. And so we just have the sheath, and then we can connect in the 1/4-inch tubing from where it would directly hook up to the ECMO circuit. So we get rid of that small radius sidearm tubing and flow directly from the ECMO circuit itself and that 1/4-inch tubing right at the destination sheath.
And thank you for sharing these pearls about distal perfusion catheter. It's definitely a tricky spot, and kinking is a huge problem. Great to hear your approach to that. And when it comes to our patient is doing great. An ischemic leg is a catastrophic complication. Let's consider another scenario. Say we need to place an Impella CP for isolated LV shock, and we anticipate this will be in for a couple of days as the patient recovers. Marwan, what are your strategies to mitigate leg ischemia?
Yeah, that's a really good question. So a groin shot, making sure that we do an angiography of the femoral and the iliac to make sure that everything is okay to accommodate a 14-French sheath. The PLOA sheath is always removed when we place it. And then if there's any issues with perfusion, we've done antegrade sheaths and getting access on the other side and donor to leg on the other side. But honestly, if that's the case, then I would feel more comfortable removing the Impella CP from there and ask the surgeons to get axillary access and placing an Impella by 5 there so that I don't have to compromise the leg even for a few hours.
Thank you, Marwan. And you mentioned that you take an angiogram, but other than that, when removing large bore access in general, whether it's a tower sheath, Impella, or percutaneous decannulation of VA-ECMO, what are some other strategies to assess for vascular patency or compromise during or after closure?
During TAVR roll, I always do a routine angiogram from either the radial or the other side to make sure that flow is not compromised and there is flow distally on angiography. In addition to obviously checking the pulses distally for those patients, but I don't rely only on just pulses. We always do a completion angiogram just to make sure that there's flow. I think that's probably the quickest way of realizing there's a problem and be able to fix it right there and then if there is.
Thank you for that. And can you discuss the causes? And of course, we want this to be a never event as well, but the causes of compartment syndrome and the need for fasciotomy in our patients?
Oh, sure. So, our muscle groups are divided up into sections or compartments that are wrapped in fascia. And compartment syndrome occurs when an increased pressure within a given muscle compartment comprises the circulation and function of tissues within that space. So the effects that we see of this is due to cellular anoxia, due to local ischemia. So when the pressure is excessive within this particular compartment, you get damage to the muscles themselves, the nerves, and an impairment of blood flow. The increase in the tissue pressure that ultimately occurs. So I think of this as that the muscle within the compartment is in some way compromised, and that leads to inflammation, myocyte necrosis, and swelling. And so what does that come from? Normally I think of ischemia, and that may be due to the cannulation itself. We may have damaged the blood vessels. You may have had a lack of blood flow to this area for a particularly long time, say even during CPR or from an arrest. So anything that compromises the blood flow initially can lead to myocyte necrosis. And then there can be ECMO-related factors, let's say fluid overload. So something has to cause damage to the myocytes. You ultimately get inflammation and necrosis. And then this increase in pressure ultimately supersedes, or I guess rises above, your arterial blood pressure. This leads to more ischemia, and you get a cycle of ischemia leading to more ischemia. And once that muscle pressure rises above the arterial pressure, then that leg is just highly ischemic. Unfortunately, fasciotomy is the way that we treat this. It's not an entirely benign process, but the only way that you can do this is that fascial planes that delineate the compartment have to be physically enlarged. It is a very tight membrane around the muscle. And so fasciotomy ultimately just is a break in that fascia so that the muscle can swell out of its usual constrained environment. The hope with that is that when you relieve the pressure has decreased in such a manner that you now can restore arterial blood flow to the leg. The challenge with this ultimately, I think, in the world of VA-ECMO is that these are already really sick patients. You're putting them through not a benign procedure. And what my experience has been is that this is highly, highly ischemic tissue. And in these patients, there are tons of ischemic mediators, vasodilators, cytokines, all that have just been sitting within that tissue bed that is ischemic. And then when you reperfuse that tissue, this patient, they're cardiogenic shock. Then they're vasoplegic because you have put them on ECMO. They may be vasoplegic for other reasons, including, evolving sepsis, mixed shock. But so when you release all of these ischemic mediators, you end up getting more vasodilation. And if this patient was already hemodynamically unstable in any way, then now you have just precipitated perhaps a hemodynamic collapse. So I think that this can be a really, really challenging situation. And that even when you think you're improving the underlying pathology by releasing the pressure in that compartment, that the untoward hemodynamic effects can sometimes be really, really hard to counteract.
Thank you so much for going through the anatomical considerations and also kind of like really illustrating the mess that we're in if we're at the point where a fasciotomy is needed. We're kind of damned if you do and you're damned if you don't. And it just makes weathering the storm for this patient even more challenging. But team, this was an incredible deep dive. And thank you so much. Anna Marwan, you walked us through the critical steps of managing limb ischemia on VA-ECMO, from recognizing the signs to placing a distal perfusion catheter and preventing complications of large bore access. These insights are life-saving. And thank you, Nasli, for leading us through another high-stakes crisis scenario. So stay tuned, everyone, for episodes in our A Crisis Control series, because when the pressure's on, the CathMasters show up. See you next time.